Hello and welcome to this Facebook live session. I'm delighted that you could join us again. I'm your host, Dr. Karan Thakur. Each week, we bring to you an expert to discuss one subject of great interest to you and to your health in order to bring to you credible information that you can use for the well-being and health of yourself and your family. And this week is no different. I am delighted to be joined by Dr. Vivek Kumar, who's a senior consultant cardiology at Indraprastha Apollo Hospitals, to discuss an issue of cardiac disease, but a very specific type of issue of valvular disease. And he will be telling us what is the latest in the field, whether you are a candidate for it, and what are the various diseases for which these newer interventions can be used. So, Dr. Vivek, welcome to our Facebook live session. Delighted to have you here with us.
Thank you so much, Dr. Karan, for your kind introduction. And indeed, it's a great pleasure to be on this platform.
Thank you for sparing your time. And I'd just like to begin with the most important question, जो कि around TAVI, TAVR, TAVR and TAVI के around है. But before we get to the procedure, हम जानना चाहेंगे कि ये किन conditions के लिए, किन cardiac conditions के लिए इस type का procedure आप लोग अपनाते हैं?
डॉक्टर करन, आई थिंक ये प्रश्न बहुत इम्पोर्टेंट है. कोई भी ट्रीटमेंट किसी इलाज के लिए होता है, ना कि यू मेक अ ट्रीटमेंट एंड देन यू लुक फॉर अ डिजीज. ओके, सो अगर ये ट्रीटमेंट हम डिस्कस कर रहे हैं, इसका मतलब है दैट दिस डिजीज इज अ प्रॉब्लम इन जनरल. वाल्व डिजीज का वैसे बाई मॉडल प्रेजेंटेशन होता है, या तो यंग एज में या एल्डरली. यंग एज में इंडिया में खासकर हमारे यहाँ रूमेटिक हार्ट डिजीज बहुत कॉमन है. बच्चों में 5 to 15 इयर्स के बच्चों में सिंपल सोर थ्रोट, अपर रेस्पिरेटरी ट्रैक्ट इन्फेक्शन होती है, एंड मोस्टली स्ट्रेप्टोकोकल इन्फेक्शन अगर होती है तो इट कैन लीड टू रूमेटिक फीवर. सो इट सेज दैट rheumatic fever bites the heart. So the fever may last for few days, but the impact of the heart may last for lifelong. So what happens that it leads to inflammatory changes in the heart valves, most commonly mitral valve, and second most is aortic valve, and it can also involve the tricuspid valve. So in young adults, because of rheumatic fever in India, we have rheumatic heart disease, and such patients may require intervention at a very, very early stage. The second presentation of valve disease is in elderlies. So valves are like doors. So it opens and closes every time the heart beats. And there's a gush of blood, there's a pressure difference between the valves, and its job is to maintain flowing of the blood in one direction. So it's continuously working. So whatever works, any mechanical thing that works for a lifelong, for a long time, there's some wear and tear happening. So what happens that as we age, these valves also have some wear and tear, and ultimately what happens that there is deposition of calcium, there is fibrosis. So there could be two possibilities. Either the valve may not be able to, the valve may not close, मतलब valve पूरी तरह से बंद नहीं हो, और दूसरा सिनेरियो है जब फाइब्रोसिस और कैल्शियम इतना ज्यादा है that valve may not open completely. So if it doesn't open, we call stenosis. If it opens up, if it doesn't close as well, we call regurgitation. So old age में aortic valve, मेरे अगर मैं रॉन्ग नहीं हूं तो करीब 60-65 years में करीब 4 to 5% cases of people can have aortic stenosis as a manifestation, that the aortic valves are not opening properly. Right. And likewise the mitral valve also can get disease because of this process.
तो आपने बहुत अच्छे से हमें समझाया कि एक्चुअली हार्ट का पूरा एनाटॉमी क्या है और उसमें वैल्व का क्या रोल रहता है और किस दो टाइप के एज प्रोफाइल्स में ये देखा जाता है. अगर हम ओल्डर जनरेशन की बात करें जिनको वैल्वुलर डिजीज है, अमूमन लोग मेरे ख्याल से हार्ट अटैक और बाकी चीजों के सिम्टम्स बड़े अच्छे से समझते हैं अब तो, लेकिन वैल्वुलर डिजीज कैसे प्रेजेंट करता है? अगर किसी को वैल्वुलर डिजीज है तो उनको कैसे अपने आप को डायग्नोज करना चाहिए कि हाँ शायद ये वैल्वुलर डिजीज हो?
आई थिंक ये बहुत रेलेवेंट क्वेश्चन है डॉक्टर करण। देखा जाए तो कार्डियक सिम्टम्स में बहुत ओवरलैप होता है। किसी को अगर कोरोनरी ब्लॉकेजेस है, मतलब कोरोनरी आर्टरी में ब्लॉकेज है, जो हम कॉमन टर्म्स में सीएडी कहते हैं, उसमें कॉमन सिम्टम्स यूजुअली चेस्ट पेन इज द मोस्ट कॉमन सिम्टम। बट अगर वो प्रोग्रेस करता है तो कॉमन सिम्टम हो सकते हैं पेशेंट को चक्कर आना और सांस फूलना। वैल्व डिजीज में भी वैसे ही जो सबसे कॉमन सिम्टम्स होते हैं वो है सांस फूलना, चक्कर आना, और बहुत लाइक इन एओर्टिक स्टेनोसिस द पेशेंट कैन आल्सो हैव चेस्ट पेन। सो आप देखिए दोनों में बहुत ओवरलैप है। सो इस सिनेरियो में एक फिजिशियन, एक कार्डियोलॉजिस्ट का बहुत इंपॉर्टेंट रोल है, एंड आई थिंक उसका जो स्टेथोस्कोप है दैट वर्क्स फॉर द डायग्नोसिस, बिकॉज we can auscultate the heart, and if we hear on a clinical examination that there are murmurs, that we can think that okay, the patient can have a valvular heart disease. But देखा जाए अगर किसी भी व्यक्ति को अगर कोई परिश्रम करने पे, किसी तरह का काम करने पे सांस फूल जाए, चक्कर आए या चेस्ट पेन हो, सो एक क्लिनिकल इवैल्यूएशन बहुत जरूरी है। दैट पेशेंट शुड विजिट physician or a cardiologist to evaluate whether what's the problem inside, whether it's related to heart valves or the blood supply of the heart.
Right. So to our viewers, I think that gives a lot of clarity that there could be overlapping symptoms, but whatever it is, you should come to an expert. So for the benefit of the viewers, I'll just repeat, if you have these type of symptoms, which are pretty much what you might be aware of in terms of what is known as heart attack or, other related things, you must come and at least rule out or at least get a proper diagnosis from an expert like Dr. Vivek Kumar, who's at Indraprastha Apollo Hospitals. So Dr. Vivek, you very brilliantly put it out to us about how the overlap can happen and the dangers of that, in the sense that we might not know and why you should come to a specialist. तो अगर कोई पेशेंट ऐसा जो इस टाइप की हिस्ट्री का हो, कोई थोड़ा एज ग्रुप हायर हो, वो आपके पास आता है, तो क्या वर्कअप आप लोग करते हैं? व्हाट कैन पेशेंट्स एक्सपेक्ट टू अंडरगो बिफोर यू कम टू ए डायग्नोसिस ऑफ वैल्वुलर डिजीज?
डॉक्टर करण, जैसा मैंने अभी आपको बताया था, दैट क्लिनिकल एग्जामिनेशन बहुत इंपॉर्टेंट हो जाता है। पेशेंट का पल्स, पेशेंट का ब्लड प्रेशर कैसा है, और ऑस्कल्टेशन यानी क्लिनिकल एग्जामिनेशन में हमें कोई मरमर सुनने में आ रहा है या नहीं आ रहा है, ये बहुत इंपॉर्टेंट फैक्टर है। बहुत बार क्लिनिकली शायद ये चीजें मिस हो सकती है। इसके बाद जो सबसे मेन इन्वेस्टिगेशन हो जाता है वो है चेस्ट एक्सरे एंड एक echocardiography. One echocardiography is needed. So echocardiography is just like getting an ultrasound of the heart. So it's very safe, widely available investigation, and echo really works the cornerstone for confirming a diagnosis of valve disease and planning future intervention. That whether it's going to be medical management or it's going to be some intervention in form of surgical or the transcatheter intervention, whatever it is. So an echocardiography becomes a very important investigation in such patients.
Right. So you've given us a good segue to now actually move to the treatment modalities. So after you have diagnosed the condition and it requires an intervention, there are two traditional ways, one traditional way and one new novel way, as one would look at it. Could you just give the options that are available for such a condition and what interventions are available?
Okay. So first of all, whenever a patient has a valve disease, the most important consideration is whether the patient is symptomatic or not. Like for example, I can say that a lot of people are, and it's a happy thing to know that a lot of people are very conscious about their health nowadays. They go for preventive health checkups, and often we have patients who have mild, moderate, or maybe severe disease incidentally found on ECG, on echo, on X-ray. So, and most of the time these patients may not be symptomatic. So if the patient is asymptomatic, that is not having any trouble because of the valve problems, then mostly the management is medical. But if the patient is symptomatic, then we start thinking about the management. And symptomatic patients with valve disease, an intervention is needed. Then comes important factor is the age of the patient. If the patient is young, in such patients, the patient needs surgical intervention. I mean, if the valve is diseased, either it needs to be replaced or corrected. So I was just, when I was talking about rheumatic heart disease, so a young patient with shortness of breath can have a mitral stenosis. This disease can be tackled by a simple percutaneous intervention we call PTMC, that is percutaneous transcatheter mitral commissurotomy, or BMV. So this is a very common procedure that is widely available. But for all other valve disease, there may be a need of a valve replacement or repair by surgical route. But if the patient is an elderly, then a lot of factors come into play. Because as you will agree that elderly patients may not only have the valve disease, the patient can have a diabetes, the patient can have a kidney issue, the patient can have a liver disease, and more commonly we see in India, because of the pollution and things, the patient have lung disease. A lot of patients are on bronchodilators. So any patient who is having a pre-existing lung disease becomes a very, very bad surgical candidate, because surgery cannot happen without putting the patient on ventilator. And such patients really do not so well on ventilators. So we have to consider the age of the patient. If the patient is elderly and the patient is having moderate to high risk, in these scenarios, surgery doesn't become an ideal choice. And I would like to share that in aortic stenosis patients, almost 1/3 of the patients are not offered a surgical treatment by way of replacement of the valve because of these risks. So what we are prescribing to the patient is a gradual death because of the valve disease previously. But with this newer intervention, I think we can give hope to such patients.
Right. So these new interventions you spoke about, they are offering new hope to people. But before I ask you about that, I just want to reiterate what you just said about the importance of getting a preventive health check done periodically, because a lot of these heart disease conditions, they are asymptomatic and they can be picked up through a simple health check. So we like to reiterate that to our viewers. Coming to the solution that you gave, could you now throw some light on these new solutions, the surgical interventions that are now available for such patients who did not have any option previously?
So continuing on where I stopped about the risks in elderly patients. So as I said, that about 1/3 of the patients were not an ideal candidate for surgical intervention because of the comorbidities. And if I talk about aortic stenosis, so there is one simple natural history that is often taught to us in our medical colleges, that a symptomatic patient, if the patient is having a chest pain, has an average survival of 5 years. If the patient is having syncope, the average survival is about 2 to 3 years. But if the patient is having shortness of breath or breathlessness, that is heart failure, the average survival is 1 to 2 years. So suppose I have a patient who is 77 years old, severe aortic stenosis, and the patient is having severe breathlessness and a lot of comorbidities. Surgery cannot happen because of the risk factors. So what prognosis I am offering the patient? I am offering a prognosis that the patient may die in 1 to 2 years, despite on medical treatment. So transcatheter intervention, which thanks to innovation in medical sciences, started in about 2002 and came and started being adopted at various centers. So over the last 20-21 years, lot of refinements have happened in this field, and now safely we can do transcatheter valve replacement for the aortic valve in the patient that I discussed. And there are data, a very strong data to back that even if the patient is prohibitive of high risk of open heart surgery, the patient can undergo safely a TAVI or TAVR procedure, and that has shown to improve survival.
So in these interventions, you are actually replacing a faulty valve or an aged valve. Is that correct?
So replacement is like a generalization of what you say when the surgeons, what the surgeons do. So if briefly, I'll just like to point at what surgeons do is that they open the chest, they expose the heart valve, obviously by putting an incision on the heart, and they cut out the degenerated valve or diseased valve, and then they implant a new valve and suture it around the annulus. Annulus is the base of the valve. Okay. What we do is that we go through a tube like which may be 6 to 7 millimeter in width. We approach that valve, we cross that valve, and we make a space, but we do not excise out the valve. What we do is that since valve is the tissue, we can put another scaffold there. The valve that we implant is basically a stent-like structure which has a leaflet inside, and the leaflet is bioprosthetic. That is a tissue valve. So we have a struts, and in between we have a tissue that works as a valve, and we take that thing there through the catheter, and we just deploy that at that very place. So what happens that the previously or the native valve, it gets compressed around the annulus. So we don't excise anything. We just compress the diseased valve around the wall, and this valve starts working immediately.
So now that we know what the procedure would actually entail, what is the success rate of such procedures?
So the success depends upon the patient's profile. So if you ask me, it's a very safe procedure compared to the surgical AVR, and the success can be more than 90-95% in most of the cases. 5 to 10% cases, there could be some issues depending upon the comorbidities that the patient can have. So just to enlighten on the eligibility of the patient who can undergo a TAVI or TAVR, Dr. Karan, I'd like to point out that initially this treatment started for patients who were a very high risk or prohibitive risk of surgical treatment. So these were the patients whom the surgeon said, God, I'm not going to touch this patient. So these are the patients whom the treatment started. But over the years, people started thinking about why not think about de novo patient, default patient of aortic stenosis. So initially, this treatment was studied in intermediate risk patients, that patients who had an intermediate risk of having complications or death after an open heart surgery. They found it to be very effective. Even it decreased the complication rates and the survival and things like that. So it became a recommendation that even in the intermediate risk or moderate risk that we call, it can be offered. Then we had trials like the partner trial and the low risk trial patients. So there it was tried in de novo patients. So a patient in one arm, there were patients who were normal patients of severe AS, elderly patients obviously, and in the other arm we had a patient who had a went TAVI, and there was not much difference in the outcomes of the two procedures. So now the guidelines have been revised. So what the guidelines today say is that TAVI or TAVR is a class 1 indication for patients having moderate to severe or prohibitive risk of surgical AVR. But in low risk patient, particularly if the patient is elderly. So for Indian patients, 65 years plus you can see it's a fairly elderly population. In such patients, even if the patient is not a high risk for surgery, we can offer this treatment because what it gives us is that early discharge from the hospital, less morbidity because we don't put the patient on ventilators. We don't have to keep the patient for a long ICU stay, and rapid recovery from after the surgery. So I'll say the patient can be up and moving in 7 days after the procedure. So because of these reasons, now in selected group of patients with even normal risk can be offered a TAVI or TAVR.
Right. So this is like a a boon for patients who were earlier not even candidates to now people who are offered this as the first port of response because of the advantages that you said. कि early discharge हो सकता है, you get back to life as normal, and the risks are much lesser because of ventilator and all. तो अगर आप हमें हमारे दर्शकों को ये बताएंगे डॉक्टर विवेक कि जब ये प्रोसीजर हो गया और आपने पेशेंट को डिस्चार्ज कर दिया, उसके बाद कितनी देर बाद वो अपना नॉर्मल रूटीन वापस उस रूटीन में वापस आ सकते हैं, वॉक शुरू कर सकते हैं या अपना काम शुरू कर सकते हैं? हाउ डज दैट प्ले आउट आफ्टर दीज इंटरवेंशंस वर्सेस जो पहले बाईपास सर्जरी या फुल सर्जिकल इंटरवेंशन होता?
सो देखा जाए अगर पेशेंट लो या इंटरमीडिएट रिस्क का है, आई मीन we have a STS score, Euro score. This is what we do as a workup to assess the patient risk factors. And that decides whether the patient is low risk, intermediate risk, or high risk for surgery. So if the patient is low risk or intermediate risk, so most of the time these patients are able to start their work after 7 days. So if you ask me mobility, so usually we keep the patient in ICU for not more than 1 to 2 days, and that is just for monitoring. But the patient is not on any ventilator, not on any intensive monitoring. It's just like routine monitoring of the BP, pulse, and the rhythm of the patient. So most of the time the patient is comfortable moving around, and after shifting the patient from ICU room में जाने के बाद भी patient are fairly mobile. So if the procedure has been uncomplicated, I'll say most of the patient can start their work after 7 days or so. But if you ask surgical area में क्या होता है, तो usually 2 से 3 दिन का ICU stay, and obviously the patient is on a ventilator at least for 24 hours for the procedure. After the procedure, there are drains put on the chest because if you close the chest and is there an internal bleed, you don't have any way to know. So the drains are put so that if there is any bleed, we are able to know that okay, there is some internal bleeding. So these tubes are there, and since the patient's chest has been opened, the lungs also get compromised. So patient needs very intensive chest physiotherapy to improve the lung expansion. So I've seen a lot of elderly patients still having breathlessness that will last for up to 1 month or more. So the total recovery after an open heart surgery in a normal patient could be more than 15 days or 30 days. So if you have a patient who have a intermediate or high risk for surgery with a lot of comorbidities, so you expect the recovery time becomes very prolonged. So this is why these treatments are now being seen as a hope for such patients.
Right. So shorter recovery, better quality of life, a lot of advantages, obviously, that you've highlighted. And also, if you could, since you have such a lot of body of work around this, could you share an example of how this intervention changed the life of a patient? What was the outcome before they came to you, or at the time when they came to you, and after you did this procedure?
So I'd like to share about 2 patients, I'll say. So 2 different patients, one with high risk for surgery, frail, 52 kg female, short height, and she complained of loss of weight about 5 to 6 kgs over the last 6 months. Because what happens that if you have a disease, every time you eat, you feel some discomfort, and often the patient get weight loss in such situation. So she was this patient, recent weight loss, short height, intermediate to high risk patient. And the other patient was a low risk patient. Both were 67 years old, pretty preserved. She had syncope, and there were no much of a risk factors. So the patient who didn't have a risk factor, she was immediately after the procedure, 3 to 4 hours of ICU care. We could shift the patient into the room the same night, and we could discharge the patient in 3 days of total admission. So the case was done in November, and 3rd was the procedure date. On 5th, she was discharged. So this was that patient, and she's I asked her after a follow-up that how are you doing and have you started, you can now start your daily shows that you do. Daily जो आप करते हो आप करो. So she's told me that doctor हम तो पहले से ही कर रहे हैं. So this is what the change happens, and it gives you a lot of satisfaction. The other patient having intermediate to high risk, frail, she was not eating well, so her recovery was slightly gradual. So she needed a though the ICU care was ICU observation was 2 days, but she needed 4 to 5 days of stay because she was not confident that she can walk around and do her things. So a lot of motivation was there that you are fine, you can go home and you are good. So it's been 1 month, she is doing fine, but yeah, her improvement and confidence, she has started eating well, she has gained weight. Otherwise, she is fine. But as you know, as I said, it all depends upon the risk factor, how fast the patient's recovery will be. But at least she is doing fine and comfortable.
Right. So these are really inspiring stories of hope and real stories, from Dr. Vivek's own practice. So that offers hope to a lot of people who are out there who probably previously did not even have that option available. Dr. Vivek, we're coming to the end of this fascinating discussion, and we could go on and on, but in the interest of time, we would have to draw this to a close. But before we do that, I wanted to ask a question that you would, in terms of the advice that you would like to give to a person or a caregiver who is looking at another elderly person at their home who may have this condition, who may require something like a TAVI, but are still in two minds, have doubts. What is your advice to them?
So I think nowadays a lot of information is available online. We also have a booklet. We must make an informed decision because look, every procedure has some risks involved. When we offer a treatment, we always do a risk-benefit analysis. And if the benefits outweighs the risk, we then say, okay, this is what I recommend to you. This is how I talk to the patient. So if the patient and the attendants understand the procedure and the benefits involved, and also the risks involved. So in that situation, we can have an informed consent and informed decision where we both, the patient and the doctor, agrees that, okay, this is the best treatment for the patient. And Dr. Karan, I would like to really highlight that the surgeons are also involved in the decision making. So it's a heart team approach that we go about for the patient. So we have a surgeon also, city-based surgeon also involved in this program because a third opinion is also needed. That, okay, if I say this is a high-risk patient or intermediate risk patient, so is it the right conclusion or not? So if the surgeon is also on the same page, then we can have a very transparent picture presented to.
That was Dr. Vivek Kumar, Senior Consultant Cardiology at Indraprastha Apollo Hospitals, who gave this fascinating insight into TAVI, and all the interventions that are available to those people who are suffering from valvular disease. So I would like to once again thank Dr. Vivek for giving us those insights. And if you do have more questions or would like to seek an appointment with Dr. Vivek, please don't hesitate to reach out to us. All our details are there on the ticker. You can also DM us on our various digital platforms and also do like and share this Facebook live session with others, with your families and friends, so that they can also benefit from the good advice of doctors like Dr. Vivek Kumar and others that we bring to you each week on these very special Facebook live sessions. So till the next time, stay happy and healthy. Thank you.